Right, good afternoon, everyone. So I'm not sure whether anybody can see me.
Yes,
They can see me. Okay, I can't see you, and I can't see anything else. It's I'll be Frean. So welcome to, I think it's our first Suitcase Club of the year. I haven't been here, so I wouldn't know whether there was another one, but it's the first Suitcase Club of the year. We all survived the Christmas holidays and the subsequent holidays, and it's a special afternoon because we've got two speakers today. We've got Professor John Frean, which is going to be our main speaker, and then we've got a special guest from the United Kingdom, Dr. Dipti Patel, from the National Travel Health Advisory Centre, NAFNAC, and the British Foreign Office, and she can correct that when she finally gets. And she's a special prize. She was dragged in last minute by Prof. Bloomberg, who's one of our long-time supporters. And Dipti is going to share just a little bit with us about the dengue vaccine, which of course we don't have, but which we think we may need in the foreseeable future in Africa with global warming and all those other good things. I'm just very quickly going to run through a few of our standard things. So Suitcase Club, we broadcasting from Fire Station Rosebank, Travel Corporate. Why the Suitcase Club? Joburg is a springboard for travel for work into Africa. Many returning travelers, some ill, no central referral center for ill returned travelers, and no surveillance. So our clinic is also GeoSentinel Johannesburg, of which Lucille and I are the co-directors. And GeoSentinel is a joint venture between the International Society of Travel Medicine and the CDC in Atlanta, USA, or as it existed pre-Trump. So we're not sure whether they're all still there. But that's a global network of travel health centers reporting back on ill-returned travelers. And it provides important epidemiological data to travel, public health practitioners, and researchers globally. And we just would like to remind you again that if you see any ill-returned travelers with infectious disease in particular, or suspected infectious disease, we'd love to hear about it. There's a very short form that we'll even fill in on your behalf, but that helps us to report back to the CDC, and that gives us an idea of what's going on in travel health globally. Prof. Bloomberg just mentioned this afternoon that we may have we have a suspected dengue case from Mozambique, and we're waiting to hear from one of our infectious disease specialists once he's seen the patient and done the bloods, whether we indeed do have a dengue. And so talking about dengue today with Dr. Patel is very appropriate. Right, there's something on GeoSentinel. If you've got cases, you can either phone us on that number or you can send an email to geos@travel.corp.com. Just a quick reminder that we've got shingles vaccine available in our clinics. It's a Section 21 drug. Zostavax is no longer available, so this is Shingrix, hugely expensive, but indicated in people who are immune suppressed. And then likewise, we've got malaria chemoprophylaxis available for children and pregnant women. We are happy now that we've got Hitavanil in the country. So we've got a form of pediatric atovaquone proguanil back for prophylaxis. We still are providing mefloquine to pregnant women and other people that may have special indications under Section 21. And you can find some detail there. And then the breaking news at 5 o'clock this morning, that came in to me from Prof. Schlim in the United States, in Jackson Hole. He got a report that comes in, we cut off the top there, but it's from the Medicines Control Council in Zimbabwe, warning the public that there is falsified rabies vaccine in circulation in Zimbabwe. And so that's the original letter, and you can see photos of the falsified vaccine on the right-hand side of the slide, but on the left-hand, the photos on the left are the false vaccines, and then the registered vaccine is on the right-hand side. And just to point out that even the registered vaccines, the genuine stuff, the packaging differs. It looks different, and it makes it hugely confusing and impossible for a layperson who gets exposed to possible rabies to know whether he's getting the real vaccine or not. Which is a reason to perhaps emphasize pre-exposure vaccinations. I quickly went to my own photo collection of taking photos of rabies vaccines that I've come across at hospitals and clinics in Africa in the last couple of years. And you can see that Abayarab, which I can't pronounce. I've got 4 different versions there, and we won't know which one of those are genuine, which ones of those are in fact also fake vaccines. The Equirab is we don't know whether that's fake, and of course that's immune globulin. That's not the vaccine. But again, what's the origin? Was it kept correctly? Will it be administered correctly? So just a little punt again for rabies, because it remains a deadly disease. And then a thank you to Sanofi. Monica is with us. Sanofi is providing very nice little snacks for those of us that are present in the flesh instead of online, like we used to do it in the old days. And then it's over to Prof. John Frean. Thanks, John. We can swap places.
Right, thank you, Albie. So this is not going to be a primer on traveller's diarrhea. I'm going to present a case that has turned up with us recently, and then quickly run through the parasitic causes of diarrhea. So not necessarily specifically related to travellers, but I think the clinical case is very relevant to those in the profession. So this is the story. It came to me via one of the ID physicians at Charlotte McKechnie, asking for help. And there's a story. I've had a Giardia infection since returning from India in January 2024. So this was late in 2024. I've lost 17 kilograms down to 67 kilos. I've had multiple rounds of treatment. The longest I've had relief is about 7 to 10 days post-treatment. Can I close this window? I believe we're back. Okay. Okay, so see, these are some of the patient's own snaps from his trip to India. I'm doing things you do in India, I guess. Back. All right, so as I said, these are some of his holiday snaps, showing some of the delights of India. And this is the tale of his treatment attempts from January going through to November last year. So I think most of these remedies you'll know about. Cantrexil is sort of coagulative treatment, isn't it? I'm not sure if people still use that.
Won't travel without it.
But there, look, multiple attempts at metronidazole, albendazole, nitazoxanide, not readily available here, but used for some protozoal infections. Ivermectin, I think, is just a shot in the dark. Desperation, probably. And right at the end, berberine is a sort of herbal remedy. I don't think it's got any specific action against Giardia. So he saw multiple visits to gastroenterologists and so on. Had gastroscopes and duodenoscopy and colonoscopy. In the end, his gastroenterologist got hold of quinacrine, and that seems to have done the trick. Although he according to the patient, that worked the best and resolved some of the symptoms, although there was some continued for a bit, but finally he recovered. So I wanted to not give a lecture on management of giardiasis, just to show you some information from the Hospital for Tropical Diseases in London, published some time ago, but I think quite pertinent. If you look on the left there, over a period of a few years, the increasing ratio of nitro-imidazole, that's metronidazole and tonidazole and related drugs. So the light bars are the ones that are refractory, and you can see the rates are going up steadily between 2008 and 2013. And they're the actual numbers. If you look on the right, now this is concealing.
They'll be able to see.
I can see it.
Okay.
Will they see it?
I see all.
Oh, they see all. Okay. But I can't. Anyway, this just indicates that. There we are.
Yes.
Okay, let's see if it. Yeah.
So the total number of travelers with giardiasis over this period, over a period, on the two left-hand columns, the numbers and percentage. So you see the largest number of travelers did come from India. These are returning travelers with giardiasis. But the percentage with refractory illness, in other words, not responding to treatment, came from India, is a much larger percentage than the number simply traveling from India. In other words, India was the major source of treatment failures for giardiasis. And I don't think this is unique experience. I think it's well described now that resistance to treatment or treatment failure of giardia infections is very common.
Just click on the actual screen. No,
No, this one.
just on the actual PowerPoint presentation.
Does it? Okay.
And then click next.
No. Okay, and now we should be able to go there again, are they?
Okay. So again, from the same unit, the agents that they use to treat refractory giardiasis. And you see a number of drugs attempted, tonidazole, metronidazole, albendazole, there's nitazoxanide again, paromomycin. And then when we get to mepacrin, that's what quinacrine is called in the UK. The response to mepacrin, you can see, is very good, with 100% patients not requiring further treatment. So it does seem that quinacrine or mepacrin, and I think this has been shown elsewhere, that it's really effective and probably the most effective treatment for refractory giardiasis. So these are the treatment recommendations taken from up to date. So they give the first choice as albendazole plus metronidazole. An alternative to that is quinacrine as monotherapy or combined with tonidazole, or metronidazole plus quinacrine. And it's important to keep in mind that there may be some degree of malabsorption and lactose intolerance simply due to the damage to the small bowel mucosa. And if symptoms do persist despite the absence of evidence of giardia infection ongoing in the form of microscopy or PCR nowadays, then suggest a lactose-free diet for a while, just until the lactase recovers. So alternative agents which might be considered, nitazoxanide, paromomycin, furazolidone, secnidazole, or nidazole would all be regarded, at least by this authority, as less optimal alternatives. So quinacrine, the bottom line is quinacrine is effective. Just keep in mind that it has some nasty side effects, some of them quite serious: psychosis, the hemolysis in G6PD deficiency, yellow skin discoloration, and then gastrointestinal symptoms. Now, for our local audience, just note that quinacrine isn't available here routinely. This patient got it on a Section 21 application. Neither is tonidazole nowadays. Neither are any of these alternative nitazoxanide, etc., etc. So we're really left with albendazole plus metronidazole in the those are the suggested doses. So just a little word about mepicrine or quinacrine. Sorry, mustn't go back. It was one of the first anti-malarial drugs in wide use, and during the Pacific stage of the Second World War, it was given routinely to US forces, I suppose other ones as well, fighting in the Pacific theater. And these are photos from that time. So Atibrin was the trade name for mepicrine, quinacrine, as it was used then. So the sign there says, "It won't do you any good to remember Pearl Harbor if you forget Atibrin." And there's a dire warning that these men did not take their Atibrin. And then some Papua New Guineans, they look a bit mystified. So I don't think they're the target of this particular publicity, but hit the target with Atibrin. So just to run through the causes of parasitic diarrhea. So you can think of this as, on the one hand, where diarrhea is the usual clinical presentation, and on the other, those parasites that may or may not cause diarrhea. And amongst the ones that typically cause diarrhea, most of them are the protozoa, with just a couple of helminths. So amongst the protozoa, we have the apicomplexans. So this is the same group as malaria, actually, but these are the intestinal coccidia, crypto, and so on. I'll show you some pictures of those and say a little bit about each one. One important amoeba, but not the only one. One flagellate, that's Giardia. One ciliate. Then the microsporidia, which aren't strictly speaking protozoa, but I'll explain that shortly. And then a couple of others of minor importance. So we're not going to discuss all the worms on the right there, because diarrhea is only incidental and often not present at all as part of the infection. So that little blue symbol up on the right indicates those parasites or parasitic diseases which are zoonotic. So Cryptosporidium, some species are zoonotic. So this is a very common cause of diarrhea, especially in endemic countries, predominantly in young children. And in what was called the Global Enteric Multi-Center Study, about more than 10 years ago now, which was carried out in India or South Asia and Africa, so it wasn't really global, but that was the most common pathogen in children apart from rotavirus, and it's still one of the dominant causes of diarrhea in developing countries in children. And there's some prevalence estimates. In South Africa, in our sentinel surveillance, we found that Cryptosporidium caused about 15% of diarrhea in young children when we did this study. So A shows the oocysts. You have to stain it with Zeal-Nielsen to show them up. B, those little dots along the border of the intestinal mucosa are the cryptosporidial oocysts. Then Cystoisospora, C and D. This is another coccidian parasite, very much an opportunistic parasite in that it can cause really severe, long-term, intractable, recurrent diarrhea in AIDS patients, even to the extent of threatening their lives. And although it may respond to treatment, it often recurs, especially in these patients. And the reason for that partly is because it can establish an extraintestinal focus of infection or nidus of infection, for example, in the biliary tract. The other apicomplexan ones, Sarcocystis is, I think, very uncommonly diagnosed. Most reports come from elsewhere. I don't know of any from South Africa, but Sarcocystis can affect humans in two ways. So we're talking about the intestinal infection here, where humans act as the definitive hosts for the parasite, and we acquire it from eating raw, undercooked beef or pork. Now, there's another form of Sarcocystis caused by other species where we get the muscle infection, but that's not relevant here. Then Cyclospora is looks similar to Cryptosporidium, although the oocysts are rather larger, and it looks somewhat we can distinguish between them microscopically. So this is a well-known cause of diarrhea, particularly in those returning from South and Central America. And there have also been outbreaks in the US related to imported food from Mexico mainly. C shows Giardia, and the preferred species name now is apparently duodenalis rather than Lamblia or intestinalis. That's the recommendation of the American Society of Microbiology. So this is a very common cause of diarrhea. Some studies, particularly in children, have shown very high prevalences in Africa, and it's not always symptomatic infection. It can be subclinical or asymptomatic, and only a proportion progress to chronic diarrhea and malabsorption and weight loss. And as we've mentioned, treatment failure is now well recognized. So it's the trophozoites and a cyst on the left, C, and D shows cysts by a different staining method. In Entamoeba histolytica, A showing the cyst and B showing the invasive form in a gut biopsy. So this is a very important cause of intestinal infection, and sometimes, as you will know, we can get extraintestinal spread, liver abscesses, and so on. But it does rank amongst one of the most important parasitic diseases on a worldwide burden of disease basis. And that global enteric multi-center study again showed that this was one of the very important causes of mortality in young children in developing countries. In developed countries, less common, but you would see it in travelers and immigrants and migrants rather than local transmission, acquisition. Then the only ciliate of importance for humans is Balantidium, now known as Balantioides coli. So this is a pig parasite, and people working with pigs in unhygienic conditions are at risk. In third world countries like Papua New Guinea, Bolivia, and so on, that's where a number of reports have come from, but also in what you'd think were more civilized countries like Poland, Denmark, and Russia. So this does have the propensity to cause outbreaks in institutions where poor hygiene exists, orphanages, prisons, mental hospitals, old age homes. Now, this parasite generally causes fairly mild illness, but does have the ability to invade and cause dysentery and more severe fulminating infection. So now, Microsporidia, so these are not true, in fact, they're not protozoa at all. They're actually more closely related to fungi. If you look at their genomics, but they behave very much like protozoa, so we're still clinging on to them as parasitologists. So this is a large group of organisms, of pathogens, hundreds, in fact, of species, but the important ones in this context causing diarrhea are enterocytozoon species and encephalitozoon, but there are others. So these are mostly opportunists in terms of causing severe disease, although they can cause milder disease in immunocompetence, but self-limiting. There's some prevalence figures in HIV positives, estimated global prevalence of 12%. Just can't see this thing. And 15% estimate in HIV in sub-Saharan Africa. That's right. And predominantly in low-income countries with give you higher prevalences. So the risk factors are, as you would think, for most of these: unsanitary living conditions, poor hygiene. Then on the opportunistic side, transplants, etc. And travelers are included amongst the risk groups. Shouldn't be into no. So just to finish off this brief parade, we've got some more unusual, although more unusually recognized, but probably quite common pathogens. There's Dientamoeba fragilis. Its importance really is causing an irritable bowel syndrome rather than frank frank diarrhea, although diarrhea may be part of that. Flatulence, anorexia, weight loss, abdominal discomfort, and very similar to what is caused by blastocystis hominis. So this is a parasite that's still looking for a home, or we may have found one now in terms of its taxonomy. At one time, it was thought to be a yeast. Another times was thought it was classed amongst the amoebae. Now it's thought to be a stramenophile, which is in the group that brown algae belong to. So, which are all environmental organisms. So this is something that's adapted to life in the gut of humans and animals, because animals can be a source. So it's a very commonly recognized, but its true clinical significance is unclear. And it may just be a marker of intestinal disruption due to other causes of diarrhea, rather than causing diarrhea by itself. So there's still, so when you see a lab report with blastocystis on it, unless it's present in huge numbers and nothing else is found, it's probably not significant. And then just to finish off with really the only helminth that consistently causes diarrhea, and which travelers to less civilized places may pick up, is Strongyloides stercoralis. So there are risk groups. It can produce infection which persists for many, many years in a subclinical form. So war veterans, for example, refugees, immigrants, travelers, and of course it is an opportunistic parasite, not particularly associated with HIV, but carriers who are given corticosteroids then become at risk for disseminated or hyperinfection. And then HTLV1 infected people also prone to hyperinfection. And it's got a wide spectrum of disease, from asymptomatic all the way to fulminating, disseminated, or even fatal. And I think that's all I'm going to talk about. Just to point out that according to UpToDate, and I'm sure you will know that most travelers' diarrhea is caused by bacteria and viruses, and parasitic diseases are really a minority. And there they give what are likely to be the most common, and the likely places that, I mean, this reflects the audience for UpToDate, which is, I guess, mostly North America, Europe. So these are the sort of things that Americans come back with, I guess. But it's largely correct. And we've covered most of these: crypto, microsporidia, cystoisospora, Entamoeba histolytica, and blastocystis. Now, a couple of areas that they single out as very bad for Nepal are bad for Giardia on Nepal and St. Petersburg. And mountainous regions of the United States. And that reflects infections in animals, contaminating water, where people go camping and drinking from mountain streams, I suppose. So I think that wraps my bit up.
Good.
Great.
Thank you very much. If there are any burning questions from the audience to Prof. Frean, then I suggest you post them in the on the chat box, and then we'll address them just now. So for now, we're going to switch from Prof. John to Dr. Dipti Patel from the United Kingdom. Thanks, Dipti.
No, thank you. It's take glasses off. It's a pleasure to be here. So I think Lucille asked me just to talk a little bit about dengue vaccine, the dengue vaccine Qdenga, which was received marketing license in the UK 2 years ago now, and the experience we've had in the UK. So it received the license 2 years ago, but we didn't. Our UK guidelines on vaccination, our Bible on vaccinations, Green Book, wasn't really updated until October last year. Our committee that looks at immunisations, called the JCVI, didn't discuss dengue vaccine until March last year, a year after it already received a licence. Now, our guidance from NAFNAC, which is the sort of meant to be the sort of UK provider of guidance around travel health related issues, our guidance at the time had been, at the moment, until you hear from JCVI, the Joint Committee of Vaccinations and Immunisations, please don't use this vaccine. But I think one of the things we discovered was that Takeda, who manufacture the vaccine, had been doing quite a big marketing campaign around this. So we certainly found that people were being given the vaccine without any official clinical guidance on it. So the JCVI travel subcommittee, and I'm a member of that subcommittee, we discussed this vaccine in March last year. And we had actually a number of expert speakers, particularly Annalise Wilder-Smith, who works with WHO on dengue vaccine. And we decided not to make a decision on the vaccine until WHO had provided an opinion on the vaccine. And our view was at travel subcommittee was this is a live attenuated vaccine, so there clearly are people that can't have the vaccine. And it's a 2-dose vaccine, 3 months apart. Quite tricky if you're a traveller going in about 4 weeks, or we tend to say in the UK, make the appointment with the travel clinic 4 to 6 weeks ahead of travel. This sort of adds a little complexity on it. Number of people who can't have it, obviously people who can't have live vaccines generally. And the Green Book was updated, as I said, in October last year, and I've just got a reference for the Green Book there if you want to read it, but it's quite detailed, the sort of thinking around the indications of the vaccine. Do I need to press them? Yeah. Okay. So when we looked at the data at JCVI, what was very clear, and they had done a number of very good studies, there was a real difference between baseline seropositives and seronegatives in terms of vaccine. So these are people who had previously had dengue vaccine and dengue infection, and people who hadn't had dengue infection. And what they found was that in people who had previously had dengue, there was very good efficacy against all. Oh, I think I might have a timer on it by mistake. There was good efficacy against all serotypes. Particularly, obviously, 1 and 2, but in seronegatives, there wasn't good enough data for us to make a decision on people who were subsequently exposed to dengue 3 and 4, but good efficacy against dengue 1 and 2. So, and you can see on this slide the sort of the efficacy was 86% against hospitalized dengue and 65% against virologically confirmed dengue. I'm really sorry about this. For seropositives. We couldn't give an opinion on the under 4s because the vaccine hadn't been tested in that age group. And the data tended to suggest that 4 to 5-year-olds were perhaps not likely to respond as well to the vaccine. So as a result of the trial data, the main concern was that I think people may be remember the Dengvaxia vaccine that was introduced in Southeast Asia in particular, which was again another live attenuated vaccine. And subsequently we found that dengue immune children in particular, there was a higher risk of severe dengue if they were subsequently exposed to the infection. So this was the caution. We were thinking about what had happened with Dengvaxia and the fact that we didn't have enough data against DenV3 and DenV4. The UK recommendations were very much that if you're seropositive, it's of benefit, but if you're seronegative, there is a theoretical concern. So the UK produced these guidelines that if you were travelling to an area where there is a risk of dengue, there is real value if you've had previous dengue infection to have the vaccine, particularly to prevent you from secondary infection and potentially more severe infection. And our guidance was basically anyone over the age of 4 could have the vaccine if they'd previously had dengue and were travelling to an area where dengue was endemic or there was an ongoing outbreak, or if they were going to work with the virus as part of their work. Now, the difficulty, of course, is how do you determine whether someone's had, how do you determine whether someone has had previous dengue infection? So the Green Book has got quite detailed guidance because in the UK, a lot of travel health services are provided in primary care or in pharmacy where perhaps they may not understand the complexity of the virus itself. So our colleagues in the Rare and Imported Pathogens Laboratory put together a detailed sort of algorithm of how you would make a decision on whether someone's had previous dengue or not, and how you might use serology to advise on previous infection. So of course, I think we'll all know that if you've got a PCR test at the time of infection, that's like the gold standard, and that's good evidence that someone has had dengue. But most travellers won't know that. And of course, we know that a lot of dengue infections will be asymptomatic. So it all sort of comes down to detailed risk assessment, looking at where the individual has travelled before, whether they've had a dengue-like illness. If they haven't had a dengue-like illness but have been in an area where they might have been exposed, you might consider doing additional serological testing. So the algorithm is there in the Green Book, but basically if you've got a traveller who's never been to a dengue endemic area, you wouldn't be recommending vaccine. If they have been to a dengue endemic area, you would ask if they've had evidence of infection, and the algorithm takes you down one route and you might consider vaccination those. But if they haven't got evidence of infection, our lab colleagues suggested this table as a way of trying to work out whether someone has previously had dengue or not. And of course, we'll all understand that the challenge is that dengue serology isn't ideal. There's a lot of cross-reactivity with other similar viruses, but also vaccination against things like yellow fever. So some guidance has been put in place for the travel health practitioner to make a decision on whether someone has had dengue previously when they've had no symptoms. And the Green Book also talks about what compatible illness is and what a compatible definition of compatible travel is in the guidance. So in practice, we've now had the guidance out for a year. I think we found at the beginning, because of how Takeda had marketed it, we had a number of individuals that had been given the vaccine who were dengue naive because we hadn't produced any guidance. And so we were getting lots of calls at NAFNAC around whether people should get the second dose of vaccine, because subsequently the guidance came out and said we shouldn't be giving it to dengue naive individuals. So we've had a sort of pragmatic approach to that group and said, look, at the end of the day, it's about informed decision making. But, now that you've given them one dose, we don't have any evidence to suggest giving them the second dose is going to increase their risk of severe dengue subsequently. So it has pretty good safety profile, but I think what we would say is that we don't know if there's been much dengue 3 and 4 circulating. So even if people have been vaccinated when they've been dengue naive, we don't even know if they've been exposed to Den 3 or Den 4. I think over time we'll become less cautious, but particularly at this stage, we felt you've got a disease that generally, for most travellers, is mild or asymptomatic, and you've got to balance this theoretical risk of increasing the chance of someone having severe dengue. So that's the approach we've used in the UK, and I think pretty much most European countries where the vaccine has been licensed are following a similar approach. Some are making the upper age limit slightly higher. WHO recommends not giving it before the age of 6, and I think Switzerland have gone with that approach. And some have put an upper age limit on. So I think Sweden have said the upper age limit is 60 because there's no data on anyone above 60, whereas most of the countries have been happy to say any age group above the age of 4. I think there are a couple of countries that are happy for non-immunes to have it, but after a detailed risk assessment, and if someone is going for a long period in an outbreak area. In the UK, we do have a sort of get out clause that you may, if the traveller really insists, and if you think, even if the lab testing doesn't give you enough reassurance that someone's had dengue, you can make a decision to give the vaccine. And I guess I don't know what it's like here, but we will have a lot of quite vocal middle-class travellers who will want to have the vaccine. And I suspect that they will get the vaccine because that's what they want.
Not yet. Don't want that.
And I guess just from a sort of a philosophical point of view, one of the things we've been discussing is that probably the people that go to travel clinics are people that are the middle class travellers who've got the money, who can afford the vaccine, and perhaps the people who might be more likely at a higher risk of severe dengue are the people that perhaps the VFR travellers who probably wouldn't even make it to a travel clinic to get advice. So that's just a really quick overview of our sort of approach. I mean, I guess you're not going to get dengue vaccine here anytime soon.
Well, I don't know. I mean, it would depend on the need. So, should we make a case for it? Because that's the first step.
I mean, I think one of the things we say that dengue we know is the most common vector-borne disease in travellers. Certainly our sort of case numbers of dengue are just going up and up and up. We've actually recently started some enhanced surveillance, so we'll get a better idea of the type of traveller who'll be getting it. But just last year we had, I think it was around 700 cases of reported, lab confirmed dengue. Of course, that's an underestimate. So it certainly is the one that's most commonly being reported in terms of our vector-borne diseases.
Yeah, so it is notifiable here from the labs, and there are 2 labs that test. But I would imagine that a number don't get tested because it's mild. It goes away. So we really don't know how much we see. Certainly it's underdiagnosed in people traveling within Africa. And I think that is an issue.
Yeah, one of the things that we were discussing in the travel subcommittee is that we don't see severe dengue, or very, very, very rare see it as well. So that was the other thing, is that how common is severe dengue, which is the thing that we're all worried about. But I think in the UK, the sort of the centres of excellence for the infectious trop diseases, I think may have seen a handful of cases over the last sort of 10 years or so.
Yeah, so that doesn't seem to be a problem in our returning travellers, severe dengue.
And then I guess the argument, so some of the arguments from the people that are very pro-vaccine is that it will mess up, if you get dengue and you get unwell with it, it messes up your
diagnostics,
or it messes up your holiday.
Oh,
yeah.
It's a difference.
You're still having got your priorities.
They've got that luxury trip to South Africa. No, I know there isn't dengue here. They've got their luxury trip to the Seychelles or something, or Maldives, and they've spent the last sort of 10 days in bed because they felt unwell.
Had one or two quite severe cases from the Seychelles. I remember one.
Yeah. They block their platelets, and then suddenly they come up, but not complicated. So we've not had dengue shock, hemorrhagic. Let's not
tempt fate.
There's maybe one today. I don't know. So the question that I do get asked is, somebody who's been working in, remember the case Sri Lanka, got dengue. They were not that well, but they got better, and now they're going back. And would you say don't go, or get a vaccine, which is not that we don't have? Chances of getting a reinfection, I guess, are quite low. I don't know. That's the kind of case we've had to deal with. Advice. Yeah.
So just to mention, in our guidance, we say if you've had dengue infection, wait at least a year before you have the vaccine. Only because of the presumed sort of immunity against all 4 serotypes for a short period of time after infection. So our guidance says wait a year and then you would be a good candidate for vaccine thereafter if you're travelling to
Again,
and yeah.
Is there any information on the duration of protection?
No, so yeah, no. So at the moment we don't have data on I think the trials were probably around 5 years ago now. But we don't have any data on duration of protection. The other thing we looked at was what if someone just has 1 dose of vaccine, and there is actually good efficacy after the first dose, but we don't know how long that lasts. So we haven't been strict about whether you must have the 2nd dose before you travel, but some countries are saying you cannot have the vaccine unless you've got time to have both doses
Before you travel.
before you travel.
No traveller in South Africa comes
3 months ahead.
before they
Yeah.
go. That's not going to happen.
on the way to the end.
So we would probably, I think we'd have a pragmatic approach and say, give the first dose now, make sure they come back for the 2nd dose when they return.
So on the chat, if anyone has questions, they must just type it in the chat and we'll read them out. But at the moment, there's nothing.
Okay, any questions around the table? I think we've
I have one to John.
okay.
So one of the big problems is diagnosis of parasitic diseases in travellers. So what do you think is a reasonable workup? Sensitivity of how many specimens? I mean, there's no problem producing them. Having had Giardia, I know. But what is reasonable? And there are many multiplex PCRs now. What is, you need to come and talk to such language.
Well, I think the availability of molecular diagnosis has made it somewhat easier.
You need to just repeat it. I can't tell you. The availability of molecular.
Yeah, the availability of molecular has, I think, has simplified things in that it's much more sensitive, and microscopy is much less sensitive. Hence the need sometimes for several specimens before you can get an identification, particularly with Giardia, where the shedding is maybe intermittent, and a single stool may not pick it up, or even 2, and you may need 3, or which is adds to the difficulty in making a diagnosis, because people don't really want to come back again and again. It depends also how desperate they are. But certainly more and more labs are now offering a PCR for often combined with often a combination for detecting Giardia, entamoeba, and maybe some others.
Thank you.
No questions.
We're on time.
Okay. If there are no other questions, I think just on both topics, what bugs me is as much as we depend to a large extent on our private medical care system, one of the big downfalls we have is a central repository of infectious disease data, because the private labs don't talk amongst one another, the private labs don't talk to the government, and the government don't talk to the private labs. And so we're sitting with a dilemma of we don't really know how much dengue we're seeing and how bad it is, and we don't really know how much. I mean, I'm always amazed at the international conferences about everybody going on about travelers' diarrhea and chronic diarrhea post-travel, and we really see very, very, very little. So maybe South Africans are just tougher, or they end up with GPs and they get treated empirically and it goes away in the majority of cases. And so we just don't know what the incidence is.
So in terms of dengue, it is a notifiable disease by a laboratory. So
They notify.
Statutory requirements.
How many people get tested?
No, that is a different thing. But the diagnosis is made, and obviously there's some diagnostic issues.
Yeah.
It is reported every month.
Yeah.
One of the challenges we have in the UK, so the only place, if you've got acute dengue, it can only be
Yeah.
diagnosed at our one laboratory in the UK. So that makes it easier. But the real difficulty they have is the travel history. So it's the forms that aren't filled in very well, which is why we're trying to see if enhanced surveillance will make a difference, so we can get a little bit more detail, some granular detail on who's getting it, and sort of like the demographics and where they've been travelling to. But for us, definitely India is the big one. Although last year actually we saw a spike from the Caribbean, and for the first time Barbados was top of our list of imported cases. But yeah, we have that advantage that we have got one lab that doesn't.
Yeah.
So we look after an NGO that mucks around. They look after wildlife reserves all over Africa. And we've had a spate recently of people with fevers that are treated for malaria, but still don't get better and have a story about a rash and retroorbital pain. And a lot of them have been sitting in the Sudan and in Chad and Central African Republic, that sort of area. And you never get to know what they have. They get better. And even if they get down here, the serology is often disappointing.
Yeah.
You know, they had a yellow fever vaccine.
Yeah.
Did they or
Yeah.
didn't they have an
No,
viral disease? And so we don't know. But the one you sent recently to Julia Bertha that ended up with Dr. Botma or something,
Yes.
Bulgheable.
Yes.
I mean, I heard from Julia that he told her when she took a good history that he was a pilot up in the South Sudan, I think.
Yeah.
And that he was one of many people that have they've been diagnosed with dengue up there. I don't know whether we actually confirmed he's dengue down
We
here.
did.
Was it dengue?
It's dengue.
Yeah.
Yeah.
See, but so now you say, well, okay, all those other APs, NGOs, they probably also had dengue, but it's very, very difficult. So now are we going to vaccinate all of those NGO members going back, working up there? Are you going to say, well, okay, that's a risk area. How much trouble are you going to go to try and get them a dengue vaccine in the absence of it being here? And that data is too little for us to convince a Takeda that's selling by the millions to come and register the vaccine. So Section 21 would be an option for selected cases.
Yeah.
There is another dengue vaccine that's likely to be licensed. I think the US, so Takeda, I think, made an initial application to the US, and I think that they withdrew their application. But there's a Butantan dengue vaccine that might be receive a license in the US in the next few years. But
What do they pay better commissions to the Republicans?
I do.
Yeah.
Okay. Lucille says we're not allowed to talk politics.
No.
So with that, thank you very much for everybody who's been attending the Suitcase Club. And please remember to send us your infectious disease cases, provided they come from across the border. We're not interested in your local tick bite fevers in the Melville Corpus. Thank you very much. And thank you very much to Dr. Cecile Olivier, who had a trial by fire today to do the technical side of all of this. I haven't got a clue how this works.
Very well.
Thank you.
Just didn't like us today.
Yeah.
Perfect.
Wonderful.